morning, everyone. Welcome to our new journal session. Today's session is organized by USMLE founder and chairman by Dr. Abdullah Masood sir. And today, Assalamu alaikum, everyone. And we are starting a very warm and welcome to everyone for joining today. It's a pleasure to have you all here. Another impressive session hosted by USMLE, where we continue our mission to guide, empower, and connect international medical graduates to another journey. Today's webinar is a part of our ongoing effort to share a real experience, practical insight, and valuable strategies that help each of us to navigate all of us, USMLE journey with confidence and clarity. Before we begin, I would like to take a moment to thank Dr. Abdullah Masood, the founder of the USMLE, for his continuous leadership and creating this incredible platform that connects aspiring physicians across the globe. Founded by 2015 by Dr. Abdullah Masood, USMLE is a nonprofit initiative committed empowering international medical graduates, particularly those from Bangladesh, in our pursuit medical career in the United States and beyond. Over the years, the USMLE is built a strong community of mentors, aspiring physicians, offering structure, guidance, and support and educational resources to help IMG navigate every stage of their journey. Our key initiatives include young physicians workplace workshops conducted both in US and Bangladesh, targeted webinars focusing on residency applications, professional development, and career platform, and comprehensive preparation program for USMLE Step 1, Step 2 CK, Step 3, OET, and residency interview. And also to support our US clinical experience and opportunities in research and publications, mental health support and membership network to promote well-being and resilience, career counseling webinars covering pathways in the United States, UK, Canada, and Australia. Beyond academics, USMLE also encouraged the philanthropic activities such as organizing medical aid for Bangladesh and actively shares educational content, success stories, and community leadership updates through this social media platform, including Facebook and YouTube. Our recent activities is the weekly health talk shows that was every weekly we go live to for community health tech show and weekly webinar for the residency or our successful students stories. And this is the one we always do the weekly, every week, the journal club presentations. So without further delay, let's introduce our guest today, the speakers, Dr. Dhruba Tasneem and Dr. Nusrat Fatima for another stories of the journal club presentation. So let me introduce myself first. I am Dr. Farhana Choudhury, and I'm graduated from Sylhet Image Osmani Medical College and achieved my master's on pathology later. And I'm a proud Step 1 student of USMLE. I'm also enrolled in the CK batch. I'm doing the mentorship of the career development program. And also I'm doing the research assistant in the research publications department. And that's all. Thank you so much for listening and joining today. And let's, without further delay, I'm introducing my two speakers, Dr. Dhruba Tasneem and Nusrat Fatima. Please, Dr. Dhruba Tasneem, unmute yourself and introduce yourself.
Hello, everyone. Thank you, Dr. Farhana, for giving me the floor. And I am Dr. Dhruba Tasneem. I have graduated from Armed Forces Medical College. My session is 2016-17. I am a USMLE aspirant, and I am honored to be attached with USMLE organization and its activities. Currently, I am enrolled into 19 USMLE Step 1 batch and the Step 2 CK batch. And I'm also a mentor of USMLE Career Development Division. That's all about me. Now I'll give the floor to Dr. Nusrat Fatima for her introduction.
Assalamu alaikum. Good morning, everyone. First of all, I would like to thank you, Dr. Abdullah Masud sir, for giving me this opportunity. I am Dr. Nusrat Fatima. I graduated from Sherebangla Medical College and Hospital in 2023 and completed my internship from the same hospital in 2024. I was enrolled in the 16th Dream USMLE Step 1 batch, and now I'm currently also enrolled in the Step 2 CK batch. I am an active member of Journal Club presentation and also a member of Career Division in Dream USMLE. Thank you all for being here.
Thank you, Tasneem and Nusrat Fatima. And I would like to start today's journal session. Our first speaker will be Dr. Dhruba Tasneem. Please start sharing your slides and start your presentation. Thank you.
Can everyone see me, my slides?
Yes, you can
Thank
start.
you. Okay. Welcome to Journal Club presentation. It is organized by Career Development Division of Dream USMLE. So today, one minute. Today, my topic is brief structure respiration practices, enhance mood and reduce physiological arousal. It is published by the Cell Reports Medicine in 2023 by the School of Medicine, Stanford University. So the modern search for effective stress management. In a world of constant demand, we need simple, fast-acting, and cost-effective techniques to address widespread mental and physiological challenges. Ancient practices like breathwork are re-emerging as powerful science-backed interventions for well-being. But how do different techniques compare, and can a practice be effective in just 5 minutes a day? So these are all the questions that we have faced during the COVID-19 pandemic era. We all were looking out for the non-pharmacological measures of well-being. So that gives us the objective for our today's topic, which is to determine if direct modulation of breathwork is more effective than passive observation like mindfulness meditation in improving well-being and reducing stress. So we have selected 4 contenders, a test of conscious control versus the passive observation, which is a Stanford-led study compared 4 different 5-minute daily practices over 28 days to see which was the most effective for improving mood and reducing physiological arousal. So the first contender is the cyclic sighing, exhale focused, a deep inhalation followed by a second shorter inhale to maximally fill the lungs, then a long extended exhale. The second is box breathing, which is symmetrical, equal durations of inhalation, breath hold, exhalations, and breath hold. Then the third party is cyclic hyperventilation, which is inhale focused, like rapid deep inhalations with passive shorter exhalations followed by a breath hold. And there is this benchmark mindfulness meditation, passive observation of breath without attempting to control it. A rigorous real-world study design was made by participants of 114 healthy adults. Duration was 28 days of assigned 5-minute daily practice. The psychological measure was daily surveys assessed mood and state anxiety before and after each session, and physiological measures were taken like wearable hoop straps, which was provided to our participants for monitoring their continuous objective data on respiratory rate, resting heart rate, and the heart rate variables. So the first finding was all practices reduce their daily anxiety. All 4 groups, including the mindfulness meditation group, experienced significant reduction in the state of anxiety and negative effect immediately following their 5-minute daily practice. This confirms that taking just 5 minutes a day for a structured practice can provide immediate relief from negative emotional stress. So among all the measures, cyclic sighing emerges as the most effective intervention for mood. When the breathwork styles were analyzed individually, the exhale-focused cyclic sighing was the clear standout. The cyclic sighing group had a significantly higher increase in positive effect compared to the mindfulness meditation group. Like breathwork overall, The mood-boosting benefits of cyclic sighing also grew significantly the more days it was practiced, an effect which was not observed in the other groups. The key differentiator: breathwork more effectively boosts positive mood. While all groups improved, the combined breathwork groups demonstrated a significantly higher increase in daily positive effect compared to mindfulness meditation. As we can see from the graph beside, that the benefit showed a compounding effect. The more days participants practice breathwork, the greater the daily improvement in their positive mood. This was a statistically significant interaction, which was not seen in the meditation group. So how to practice this way? Your 5-minute protocol is to how to practice cyclic sighing. First, you have to sit or lie down, inhale slowly through your nose to fill your lungs. And second, once your lungs feel full, take another short, sharp inhale through the nose if possible to expand them completely. I must say that this second inhale is really crucial. And then the third step is exhale slowly and fully through your mouth. Make exhale significantly longer than the 2 inhales combined. And fourth is repeat this pattern continuously for 5 minutes every day. So the benefits of approaching this breathwork is the superiority to mindfulness, the effect of adherence, and the clinical versatility. The effect of adherence is the benefits to positive effect increase the more days the protocol is practiced, making it a sustainable tool for long-term stress management. Clinical versatility is that as a 5-minute daily practice, it provides a fast-acting, low-cost intervention for patients who require immediate tools to manage acute stress and introspective trigger. So why does intentional breath control work so well? It is because of the 3 mechanisms such as direct vagal tone influence, heart-lung synchronization, and brain modulation. The direct vagal tone influence works by prolonging our exhalation, directly stimulate the vagus nerve, which is a primary pathway of the parasympathetic nervous system, producing a near-instant calming effect. The heart-lung synchronization is that heart rate and lung function are closely synchronized. Inhales increase heart rate while exhales decreases it. The brain modulation, slow breathing rhythms like sighing, can signal brain structures associated with behavior arousals such as inhibition of our locus coeruleus to promote a sense of calm. And here I have drawn a physiological cascade for better understanding the process. Is like cyclic sighing causes prolonged exhalation, which stimulate our vagal efferent input, which in turn stimulates the nucleus tractus solitarius activation and inhibit the locus coeruleus. The locus coeruleus reduces the norepinephrine release, and amygdala threat signaling is also inhibited. It reduces our sympathetic tone, and heart rate and respiratory rate decreases, which instantly improves our mood and reduce arousal. The clinical relevance of our journal is that breathing trainings has been shown to improve the quality of life for asthmatics and to decrease use of bronchodilators. Slow breathing at a rate of 6 breaths per minute reduces chemoreceptor reflex response to hypercapnia and hypoxia compared with spontaneous respiration at 15 breaths per minute. Impairment of baroreceptor reflex sensitivity plays a role in the etiology of hypertension, and how we breathe has numerous other major health implications. Heart rate and blood pressure decrease with slow breath in patients with essential hypertension. And also, lastly, the mere act of inhaling has been shown to increase alertness levels and learning in humans. So the adaptation of this technique for anxiety and depressive disorder is that it reduces negative affect. Boosting the positive effect by cyclic sighing was more effective than mindfulness in increasing positive effect. But the most important factor is the control factor, because a perceived loss of control is a hallmark of anxiety. The simple act of taking control over a fundamental physiological process itself can reduce anxiety in these patients. Deliberate breathing provides a perceptual window that allows the individuals to recognize and then reduce the physiological signs of stress through a heightened sense of control. So the study limitations for this journal is it was remote controlled, like researchers had less control over how precisely participants followed the breathing instructions. It was self-reporting. Adherence was based on daily surveys rather than automated timestamping. Duration was only limited to 4 weeks with no longer follow-up to see how the effect lasts. And sample size was individual subgroups were relatively small, limiting the statistical power to compare different breathwork types against each other, though the combined breathwork versus meditation comparison was sufficiently powered. So with that, I want to conclude my presentation with the 3 key takeaways from this landmark study. The first one is breathwork is superior tool for building positive mood. Just 5 minutes a day can hack your vagus nerve and delivers measurable improvements that outperform mindfulness meditation and compound over time. And 2 is Excels are the key. Excel-focused practices like cyclic sighing appear more effective for boosting positive effect and reducing physiological arousal like respiratory rate, heart rate, and heart rate variability. And the third one is active control matters because intentionally controlling your breath is a direct lever into your nervous system, providing a benefits that may go beyond passive observation. Thank you. Thank you for listening to me. I'd like to hand over to Dr. Farhana now.
Thank you so much. That was so outstanding presentation, Dr. Dhruba. I would like to request my another speaker today, Dr. Nusrat Fatima. Very welcome to today's speaker's presentation. Would you mind to share your screen?
Okay, now you can see.
Yes, we can see it.
Okay. So our today's journal case presentation. The mic is okay. You can hear me.
Yes, the mic is okay. You can start slideshow.
Okay. Thank you. So our today's journal case presentation is about Zollinger-Ellison syndrome that was unmasked during hiatal hernia evaluation. And the case was led by Ramia Vasireddy in the Department of Internal Medicine in Baltimore, USA in 2025. This is a case report on diagnostic challenges and multidisciplinary management. This is a rare gastrological disorder, and we focus in this case in the diagnostic delay and surgical management. In our case, there was a 76-year-old female having perforated duodenal ulcer and gastrinoma recovery. So what is Zollinger-Ellison syndrome? It is a rare clinical syndrome characterized by hypersecretion of gastrin from neuroendocrine tumors called gastrinoma, leading to excessive gastric acid production and severe peptic ulcer disease. So the pathophysiology of ZES is gastrin drives histamine secretion by gastric enterochromaffin-like cells, prompting excessive hydrochloric acid production by parietal cells, resulting in ulcer formation and gastrointestinal complication. The annual incidence of ZES is 0.5 to 2 per million population. The average diagnostic delay is 5.9 years from symptoms onset due to non-specific presentation and rarity of the condition. The patient in this case had been suffering from the heartburn, abdominal pain and bleeding, diarrhea, and potential for GI tract rupture. So we performed serum gastrin levels and some imaging. The patient profile was 76-year-old female with hypertension. She never smoked with insignificant family history for malignancy. She didn't use any of NSAID or opioids. She had a history of acute onset of back pain, generalized abdominal discomfort, and nausea over 2 days. vitally stable except for mild tachycardia. Our physical examination was diffuse abdominal tenderness with guarding and rigidity, and the other laboratory diagnostics were within normal limits. Then we performed CT scan with contrast that revealed posteriorly perforated duodenal ulcer and prominent hiatal hernia. So we immediately performed exploratory laparotomy for acute abdominal perforation. And intraoperatively, we found duodenal diverticulum with acute perforation, abscess formation extending to porta hepatis, and involvement of distal common bile duct. So we immediately repaired the duodenum primarily. Then we repaired bile duct with choledochojejunostomy and placed a drain. The drain, named Jackson-Pratt drain, was removed on postoperative day 2. Patient was discharged with plan for close follow-up with surgery and primary care physician. So the post-surgical course were immediately after postoperative, patient discharged home after primary repair of duodenum and bile duct reconstruction with choledochojejunostomy. The drain was removed on postoperative day 2. After 2 months, the patient developed worsening nausea, acid reflux, and vomiting. These symptoms were refractory to initial management. So our initial diagnoses were related to the symptoms incorrectly attributed to the prominent hiatal hernia noted on prior CT imaging. Patient started on PPI and referred for robotic hiatal hernia repair. During preoperative assessment for hiatal hernia repair, endoscopy was performed and we revealed multiple gastric mucosal masses, leading to the correct diagnosis of Zollinger-Ellison syndrome. In endoscopy, we saw multiple mucosal masses involving the mid-stomach. Histopathology revealed a well-differentiated grade 2 neuroendocrine tumor, consistent with gastrinoma, fundamentally changing the clinical diagnosis and management approach. In immunohistochemical markers, we did the chromogranite and synaptophysin, and they both showed positive result. Ki-67 proliferation index was still low, 7%. We did some laboratory findings like fasting serum gastrin level that was 209 picogram per milliliter, and the calcium level was normal. So then we moved to the advanced imaging named 68 gallium dotated PET scan. And this scan utilizes radio-labeled somatostatin analogs that bind to neuroendocrine tumor cells with high affinity and spatial resolution. The mechanism of action of this imaging is somatostatin receptors are highly expressed on gastrinoma cells. The radio-labeled analogs specifically target this receptor, enabling precise localization and detection of small lesion, including occult primary tumor. The sensitivity of this imaging is 93% and specificity is 96%. In our case, there was increased uptake throughout gastric wall, particularly in antrum. The absorption rate was 8.96, confirming gastrinoma localization. So we did near total gastrectomy. Given the diagnosis of gastrinoma with multiple gastric masses, a near total gastrectomy was performed as the definitive surgical treatment for curative intent. Pathology examination of the resected specimen confirmed clear margins with no evidence of residual tumor at the surgical margins. Following the surgical procedure, the patient experienced complete resolution of the symptoms. She was not facing nausea, acid reflux, and vomiting. So we found excellent clinical response after doing the near total gastrectomy. Patient was discharged with a plan for outpatient surveillance with serial imaging. All surveillance imaging has remained negative, indicating no recurrence or metastatic disease. So, we face some diagnostic challenges in this disease. So, number one is non-specific symptoms. Common symptoms of nausea, vomiting, and epigastric pain. Sometimes we misguided with GRD like gastroesophageal reflux disease and peptic ulcer disease, leading to misdiagnosis. Number two, rarity of condition with an incidence of only 0.5 to 2 per million population annually. ZES is rarely considered in the differential diagnosis. Number three, proton pump inhibitor masking effect. Widespread use of PPI can mask symptoms and interfere with diagnostic testing by suppressing gastrin secretion. Number four, refractory to standard therapy. Symptoms that are refractory to standard PPI management should prompt consideration of ZES, but this is often overlooked. So, the diagnostic delay in this case is 5.9 years in average, and it's almost 5 years to take typical diagnostic delay in modern practice. So, we have to do some biochemical test like serum gastrin level, and then if we found elevated level of gastrin, we should do the secretin stimulation test. That is the confirmatory test. Paradoxical increase in gastrin after secretin injection is diagnostic. We have to look the gastric acid secretion. We have to measure basal as stimulated acid output, elevated in ZES but less commonly used. Then we have to perform upper GI endoscopy. We have to perform tissue biopsy, and the timing frame of the upper GI endoscopy is within 4 weeks post-surgery for perforated ulcer of unclear etiology. Then we need to do some imaging like CT MRI, then 68 gallium dotated PET scan test, and somatostatin receptor scintigraphy. So our clinical takeaways and recommendation for this case are high index of suspicion. ZES should be considered in patients presenting with refractory peptic ulcers or those without common risk factor, including NSAIDs, smoking, alcohol. Timely endoscopy. Endoscopy is recommended within 4 weeks after repair of a perforated duodenal ulcer of unclear etiology. 4 weeks of window, this is the critical for diagnosis. Multidisciplinary collaboration. Complex cases require coordinated care involving gastroenterology for endoscopy and diagnosis, surgery department for tumor resection, pathology for tissue analysis, and radiology for advanced imaging. And avoid diagnostic masking. Incidental findings such as hiatal hernia should not obscure the diagnostic evaluation. Sometimes PPI therapy can mask symptoms and interfere with gastrin testing. Early recognition and thorough evaluation are essential for improving patient outcomes in rare conditions like ZES. So we have to take some look over. High index of suspicion is critical when presentations don't fit typical patterns or are refractory to standard therapy. Timely diagnostic evaluation. Endoscopy within 4 weeks of unclear ulcer perforation prevents misdiagnosis and enables curative treatments. Multidisciplinary collaboration between gastroenterology, surgery, pathology, and radiology department is essential for optimal patient management. And the last is awareness of diagnostic masking, including incidental findings, PPI effects, prevents premature diagnostic closure, and ensures comprehensive evaluation. Thank you all for being here. Now I would like to take up to the Farhana Choudhury Apu. Thank you.
Thank you so much, Nusrat Fatima. There's another outstanding speak on today. I'm very happy to have this two best speaker of our session, Dr. Dhruba and Nusrat Fatima, and welcome Nusrat Fatima for the second session. It's so nice presentation. I really like it, and the topics was also very interesting because our peptic ulcer disease is very common symptoms. I will come to you for more questions.
Okay.
Now I'm watching in the Facebook. We haven't get any questions in the Facebook Live yet, but I will start the question session with Dr. Dhruba Tasneem. Tasneem, you ready?
Yeah, sure.
Yes, thank you. You hear me. Thanks. So my first question is about your presentation. Why did you choose this topic for today's presentation?
Okay, so as we all know that this is a student-led program, so I was thinking about what can help us as students, which would be a good topic for us to process this information and everything that we learn every day. So with that, I have found this topic, and I've chosen this because we are going to face a challenging exam of 7 hours, and it is very obvious that many of us can get anxiety or panic attacks during the exam, and as well as during preparation due to the enormity of our syllabus. It is overwhelming. So I want all of us to remember that if we feel overwhelmed, and immediately we can, during the blocks or taking exam, please remember that you can do cyclic breathing and immediately shift your autonomic balance towards the parasympathetic dominance and start your block or study in calm mind. Because when we're anxious, it is very common that we forget the contents we have studied. So this journal at least gives us an idea of instant relief of anxiety and help us navigate our feelings of helplessness. So this is why I wanted to present this to help us actually.
That's nice. It's really helpful. Why did you mindfulness perform less strongly than breathing?
Okay, this is really like very physiological issue. Is as we can say that the meditation is a top-down pathway. Like you have to have your conscious attention of breath, and you have to stay in the present moment. And by activating your prefrontal cortex and anterior cingulate cortex, but it is not actually possible in an anxious state for us to focus on our breath, for us to focus on our attention, and because মানে অ্যাংজাইটিটার কারণেই তো আমরা অ্যাটেনশন দিতে পারছি না। সো meditation, if you want to get improvement from meditation, you need a learning curve. You need to practice it every day. You need to learn it. But for acute conditions, like this, our cyclic sighing, it is immediately suppress our sympathetic tone. It immediately involves our brainstem nuclei and reduces the মানে এটা তখন হচ্ছে কি আমাদের অনেক কগনিটিভ ইফেক্ট গুলোকে এটা দরকার হয় না। It does not need our focus attention even though we are very disorganized, or even though we are feeling very helpless. We can instantly calm ourselves by doing this without even focusing on our attention. That is why the meditation is good if you can practice it for the long term, and you have a learning agenda, you have a mentor for you. But for us, the anxiety attacks and panic disorder patients, an immediate tool is this cyclic sighing. That's why it is superior to meditation.
Thank you. That's really helpful. And my next question is, now, what are the major limitations of this study?
Okay, so the major limitations is that this study were taken during the pandemic era. So it was actually done remotely, like completely remote. It was remotely done. And the short term outcomes only is our like মানে আমরা হচ্ছে শর্ট টার্ম আউটকাম পাচ্ছি মাত্র 28 days এর। আমরা এখানে যেটা প্রবলেম যে আমরা কিন্তু লঙ্গার এফেক্ট এটা কিভাবে হেল্প করবে সেটা আমরা পাচ্ছি না। Then it was reliance on self-reported mood scales. দেন হেলদি পার্টিসিপেন্টস, আমাদের পার্টিসিপেন্টস ছিল 114, আর তারা সবাই মোটামুটি হেলদি ছিল। বাট আমরা এটা চাচ্ছি এমপ্লয় করতে অন দি ডিজিজ পার্সন লাইক অ্যাংজাইটি, পিটিএসডি ও ডিপ্রেস পেশেন্ট। সো এটার সাথে আমরা এখনো এটাকে ম্যাচ করতে পারি নাই। সো এবং এটা কোনো ডাইরেক্ট নিউরো ইমেজিংও আমাদের কাছে অ্যাভেলেবেল ছিল না। I think these are the major limitations for this study.
Even there's a lot of limitations, the study
Yeah.
was really good and helpful. Our আরেকটা question ছিল যে if what we can do if we do this research further, or like what should we include in this research
Okay,
for
so
future?
I think a long-term adherence study would be helpful. And if we can do it as a clinical trial, like on clinical population, and like anxiety patient, PTSD patient, and if there is neuroimaging available before and after the session of cyclic breathing, that would be very helpful for us to find out in future that what it can help actually.
Thank you so much, Dhruba Tasneem. I'll come back to you if I have more questions. I would like to move to Dr. Nusrat Fatima. Are you ready? I have some questions for you.
Yes, of course.
Yes. So my first question is, what clinical features do you think in this patient suggested to diagnosis beyond a simple hiatal hernia or a peptic ulcer disease?
So, এটা আসলে নর্মালি আমরা ফার্স্টে পেপটিক আলসার ডিজিজ হিসেবেই ট্রিট করি। দেখা যায় যে 99.9% কেসেই আমরা মিসডায়াগনোসিস হিসেবে আমরা পেপটিক আলসার ডিজিজ হিসেবে ট্রিট করছি। দেন ইমেজিং এও হায়াটাল হার্নিয়া যদি চলে আসে দেন আমরা সার্জারির জন্য রেডি হচ্ছি। সো জোলিঙ্গার এলিসন সিনড্রোমটা আসলে খুবই রেয়ার একটা ডিজিজ। তো এই পেশেন্টের যেটা ছিল ব্যাক পেইন, অ্যাবডোমিনাল পেইন প্লাস ডায়রিয়া ছিল। সো আমরা এটা কনসিডারেশনে আনবো যে ডায়রিয়াটা হচ্ছে কেন, যেহেতু আমাদের হাইড্রোক্লোরিক অ্যাসিড সিক্রেশনটা এই জোলিঙ্গার এলিসন সিনড্রোমে বেড়ে যাচ্ছে। সো ফ্যাট অ্যান্ড প্রোটিন অ্যাবজর্পশনটা কমে যাচ্ছে। সো দেখা যাচ্ছে যে তার ডায়রিয়ার সাথে এই সমস্ত অ্যাবজর্পশন ম্যাল অ্যাবজর্পশনের কারণে স্টেটোরিয়া পাওয়া যাচ্ছে। তো পেশেন্টের কিছু সিমটমস অ্যান্ড সাইন আমাদেরকে এদিকে নিয়ে যাবে যে আমরা একটা রেয়ার ক্লিনিক্যাল ডিসঅর্ডার যেটা জোলিঙ্গার এলিসন সিনড্রোম হিসেবে ভাববো। যদিও এটা আসলে সবসময় মিসডায়াগনোসিস হচ্ছে, বাট আমাদের এটা মাথায় রাখতে হবে যে এই সিমটমস গুলো পাওয়া গেলে আমরা পেশেন্টের একটা গ্যাস্ট্রিন সিক্রেশন টেস্ট যেটা লেভেলটা দেখবো, যদি এটা বেশি আসে তখন আমরা জিএস হিসেবে আমরা কনসিডার করতে পারি।
Okay, thank you. How did you think like this hiatal hernia contribute to diagnose masking this case?
ইন দিস কেস পেশেন্ট ফার্স্টলি আমাদের কাছে আসছে পারফোরেটেড ডিওডেনাল আলসার নিয়ে। সো আমরা এটার জন্য ডিওডেনাম রিপেয়ার করেছি অ্যান্ড পেশেন্টকে আমরা নর্মালি প্রাইমারি কেয়ার ফিজিশিয়ানের কাছে পাঠিয়ে 2 মাসের জন্য ফলো আপে পাঠিয়েছি। পেশেন্ট 2 মাস পরে আমাদের কাছে অ্যাকিউট সিমটমস নিয়ে আবার ব্যাক করেছে যে পেশেন্টের ব্যাক পেইন, অ্যাবডোমিনাল পেইন আবার হচ্ছে। সো তখন আমরা যেহেতু শুরুতে একটা সিটি করেছিলাম তখন আমরা সেখানে হায়াটাল হার্নিয়া পেয়েছি। সো অ্যাকচুয়ালি পেশেন্টের ক্ষেত্রে আমরা ডায়াগনোজ করছিলাম যে এটা হায়াটাল হার্নিয়া। সো হায়াটাল হার্নিয়া রিপেয়ার হিসেবে আমরা সার্জারি ডিপার্টমেন্টে সার্জারির প্রিপারেশন নেওয়া হচ্ছিল। দেন এটা একটা প্রি অপারেটিভ হিসেবে আমরা একটা এন্ডোস্কোপি করাতে গিয়েছি অ্যান্ড সামটাইমস ইনসিডেন্টালি আমরা অ্যাকচুয়াল কারেক্ট যে ডায়াগনোসিস সেটা পেয়ে গেছি, জোলিঙ্গার এলিসন সিনড্রোম, বাই ডুইং এন্ডোস্কোপি অ্যান্ড বায়োপসি।
Okay, thank you. So my next question is, what are the red flags that should promptly suspicion Jollinger Ellison syndrome patient to recurrent or refractory gastrointestinal symptom?
তো পেশেন্ট জোলিঙ্গার এলিসন সিনড্রোম হলে নর্মালি গ্যাস্ট্রিনোমা হবে, যেটা একটা নিউরোএন্ডোক্রাইন টিউমার। সো এইটার জন্য পেশেন্টের অ্যাসিড সিক্রেশনটা বেড়ে যাচ্ছে। তো অ্যাসিড সিক্রেশনের জন্য পেশেন্টের অ্যাবডোমিনাল পেইন, ব্যাক পেইনস অ্যান্ড আদার্স, ডায়রিয়া অ্যান্ড আদার্স যে টিপিক্যালি সিমটমসগুলো নিয়ে আসবে। আমাদের কাছে আসলে শুরুতে আমরা আসলে পিপিআই দিয়ে জিনিসটা পেশেন্টটাকে ট্রিট করতে চাচ্ছি। সো রেড ফ্ল্যাগ হিসেবে ফার্স্টেই যেটাকে আমরা বলবো সেটা হলো যে আমরা পিপিআই দিয়ে গ্যাস্ট্রিন যে সিক্রেশন সেটাকে সাপ্রেস করে দিচ্ছি। তো আমাদের প্রাইমারি যেই ল্যাব মার্কিংটা থাকে গ্যাস্ট্রিন ইনক্রিজ, সো এই পেশেন্টের ক্ষেত্রে আমরা পাচ্ছি গ্যাস্ট্রিনটা ডিক্রিজ। সো আমাদের এই ক্ষেত্রে নিজেদের বুঝতে হবে যে যেহেতু আমরা পিপিআই দিয়েছি, সো আমাদের এই পেশেন্টের গ্যাস্ট্রিন সিক্রেশনটা 1000 পিকোগ্রাম পার মিলিলিটার থেকে কমই আসবে। এই পেশেন্টের ক্ষেত্রেও সেম হয়েছে, পেশেন্টের 209 এসেছে। সো আমরা দেন এই পেশেন্টের জন্য যেহেতু বললাম যে প্রি অপারেটিভলি এন্ডোস্কোপিক করতে গিয়ে এই পেশেন্টের ধরা পড়লো যে জোলিঙ্গার এলিসন সিনড্রোম হয়েছে। তো আমাদের রেড ফ্ল্যাগ হিসেবে আমি যেটা মার্ক করেছি সেটা হলো যে আমরা এটাকে পেপটিক আলসার ডিজিজ কিংবা জিআরডি হিসেবে ট্রিট করছি অ্যান্ড পিপিআই দিয়েছি। তো এটা আসলে মাস্কিং করে দিচ্ছে যে পেশেন্টের একটা ক্যান্সার আছে।
Right. আমার একটা কোশ্চেন ছিল, when is the secreting stimulation test is indicated and how it is diagnostically significant?
অ্যাকচুয়ালি দ্য সিক্রেশন যে টেস্টটা আমরা দিচ্ছি সেটা আসলে ফার্স্টে আমরা পেশেন্টের সিমটমসটা দেখব। জোলিঙ্গার এলিসন সিনড্রোম যদি হয়, পেশেন্টের ওয়ান অফ দ্য সিমটমস হলো হার্টবার্ন অ্যান্ড আদার্স অ্যাবডোমিনাল পেইন, অ্যান্ড আমরা যেটা পাবো সেটা হলো পারফোরেশন। এই পেশেন্টের প্রাইমারিলি আমাদের কাছে এসেছিল পারফোরেশন নিয়েই। সো আমাদের আসলে ওখানে ধারণা করতে হবে যে পেশেন্টের পারফোরেশনের কজ কি কি হতে পারে, অ্যান্ড আননোন ইটিওলজি থেকে যদি পেশেন্টের আলসার হয় তখন আসলে আমরা এই সিক্রেটিন টেস্ট, গ্যাস্ট্রিন টেস্ট দিব। অ্যান্ড সিক্রেটিন টেস্ট ইজ দ্য কনফার্মেটরি টেস্ট ফর জোলিঙ্গার এলিসন সিনড্রোম। যদি আমরা পিপিআই দিয়ে গ্যাস্ট্রিন সিক্রেশনটাকেও কমিয়ে দিই, তারপরেও আমাদের দেখা যাবে সিক্রেটিং ইনজেকশন দেওয়ার পরে গ্যাস্ট্রিন লেভেলটা আমরা একটু বেশি পাবো। তো এটা একটা কনফার্মেটরি টেস্ট হিসেবে ধরা হয়।
Okay, thank you. I have another questions like saying that what are the indication to performing like near gastrectomy, like near total gastrectomy in this case? What was the indication for this?
ওকে, জোলিঙ্গার এলিসন সিনড্রোমে যেটা আমরা পাই গ্যাস্ট্রিনোমার এই ক্যান্সারটা মেইনলি হয় ডিওডেনাম কিংবা প্যানক্রিয়াসে। খুব রেয়ার কেসে এটা স্টামাকে হয়। আমাদের এই কেসে পেশেন্টের এই টিউমারটা, এই নিউরোএন্ডোক্রাইন টিউমারটা পাওয়া গেছে স্টামাকের অ্যান্ট্রামে। সেখানে অ্যাবজর্পশন রেটটা খুবই বেশি ছিল, 68। পেট স্ক্যান যেটা আমরা করেছি সেটা থেকে আমরা ডেফিনিটিভ ভাবে জানতে পেরেছি স্টামাকে পেশেন্টের টিউমারটা আছে। সো এর ফলে আমরা সার্জারি ডিপার্টমেন্ট থেকে এই কেসের ক্ষেত্রে পেশেন্টের স্টামাকটা রিসেকশন করার ডিসিশন নেই অ্যান্ড নিয়ার টোটাল গ্যাস্ট্রেক্টমি করে পেশেন্টের সবগুলো মার্জিন ক্লিয়ার আছে এইভাবে আমরা প্যাথোলজিতে দেখে দেন আমরা এনশিওর করি পেশেন্টের কোনো টিউমার অবশিষ্ট নেই পেশেন্টের বডিতে। সো দ্যাটস ওয়াই এটার ডেফিনিটিভ সার্জিক্যাল ম্যানেজমেন্ট ইজ নিয়ার টোটাল গ্যাস্ট্রেক্টমি।
Right. In this case, it was that was helpful. Thank you. And what is how we can follow up, or what is the surveillance policy to recommended for after curative surgery for gastrinoma? What do you think?
তো পেশেন্টের আমরা নিয়ার টোটাল গ্যাস্ট্রেক্টমি করার পরে রেগুলার 4 to 6 উইকস পর পর আমরা একটা ইমেজিং দিব যে পেশেন্টের রিকারেন্স হচ্ছে কিনা, অ্যান্ড সাথে গ্যাস্ট্রিন লেভেলটা আমরা চেক করব। যদিও গ্যাস্ট্রিন লেভেলটা আসলে পিপিআই এর জন্য মাস্কিং হয়, সো আমরা যেটা প্রেফার করি সেটা হলো 68 গ্যালিয়াম ডেন্টেড যে পেট স্ক্যান টেস্ট, যেটা ডোটাটেড পেট স্ক্যান, সেটা করব। প্লাস সাথে একটা সিটিএমআরআই করে দেখবো যে পেশেন্টের আর কোথাও কোনো গ্যাস্ট্রিনোমা রিকারেন্স হলো কিনা। সাথে আমরা আরেকটা যেটা টেস্ট করব, যেহেতু ওনার রেয়ার একটা ডিজিজ হয়েছে, সেটা আমরা KI67 নামে একটা টেস্ট করব, যেটার মাধ্যমে আমরা বুঝতে পারবো যে সেল প্রলিফারেশন মানে ওই সেলটা সেল ডিভিশনের কোন ফেজে আছে। তো যদি সেটা বেশি আসে তখন আমরা বুঝতে পারবো পেশেন্টের আবার রিকারেন্স একটা ক্যান্সারের দিকে যাচ্ছে।
Thank you so much. That was so really helpful, all those answers of my questions. And I would like to end today's session. I did not see any questions coming in the Facebook Live. So I would like to ask my two speakers before I conclude the session. At first, I like to ask Dr. Dhruba's name. How you like it? How's the presentation today? How you feel it to be here?
Okay. Today was my first presentation. I was very nervous, but আমার মনে হয় যে প্রেজেন্টেশনটা কন্ডাকশন করা অ্যান্ড আমার সাথে যে ডক্টর নুসরাত ফাতেমা প্রেজেন্ট করলো, আমাদের দুজনের প্রেজেন্টেশনটাই আমার খুব ভালো লেগেছে। লাইক প্রেজেন্ট করতে পেরেও অনেক ভালো লেগেছে, কারণ এটাতে আমি আসলে একটু নার্ভাস থাকতাম সব সময়। বাট আজকে ড্রিম ইউএসএমএলই কারণে আমি প্রেজেন্টেশন করতে পেরে আসলেই হ্যাপি, অ্যান্ড থ্যাংক ইউ টু ইউ আপু for conducting this session very nicely, and thank you to Dr. Abdullah Masood sir for giving us this platform. I am very happy and grateful to our organization.
Thank you. We always love all of our students to see in this platform all the time. Thank you for joining today. My last concluding speaker, Dr. Nusrat Fatima, please, would you like to share some experience to be here?
প্রথমে আব্দুল্লাহ মাসুদ স্যারকে থ্যাঙ্কস। এটা আসলে আমাদের জন্য একটা বড় অপরচুনিটি। তো দেখা যাচ্ছে যে আমরা আসলে খুবই নার্ভাস থাকি, অ্যান্ড এটার মাধ্যমে জার্নাল ক্লাব প্রেজেন্টেশনের মাধ্যমে আমরা দুইটা দিক থেকে আসলে বেনিফিটেড হচ্ছি। একটা, আমরা আসলে যেই মডার্ন টেকনোলজি অ্যান্ড জার্নালস কেস নিয়ে আমরা জানছি, সেটা আসলে নিজেরটার সাথে আপু যেটা আমাদের সাথে আরেকজন যে প্রেজেন্টার থাকে তারটা সম্পর্কে আমরা খুব ডিপলি জানতে পারছি, এবং কোয়েশ্চেন আনসার সেশনের মাধ্যমে আমাদের সেই কনসেপ্টটা ক্লিয়ার হয়ে যাচ্ছে। অ্যান্ড সেকেন্ডলি যেটা ইম্পর্টেন্ট সেটা হলো যে আমি আসলে খুবই নার্ভাস পারসন। সো এভাবে আসলে আমাদের জার্নাল প্রেজেন্টেশনের মাধ্যমে আমরা আমাদের রেসিডেন্সি ইন্টারভিউ, অ্যাপ্লিকেশন ইন্টারভিউ সবকিছুর জন্য আমরা প্রিপেয়ার হতে পারছি। অ্যান্ড আপু, আপনাকেও থ্যাংক ইউ, ফারহানা চৌধুরী আপু, এত সুন্দর হোস্টিং করার জন্য। অ্যান্ড থ্যাংক ইউ ধ্রুব তাসনিম for a nice presentation. Thank you all.
Thank you, both of you, to joining today. And thank you, our platform and giving us the opportunity, Dr. Abdullah Masood sir, to making this Genius Family platform to make all of us to serve and study and present us and to be confident. And that's it. Today's session, I would like to conclude. And thank you so much to speakers. Thank you, our Facebook Live, all those viewers for joining today. I would like to end today's session right this now. Assalamu alaikum. Thank you, everyone.